Yeah, so I'll be speaking today about our recently published randomized controlled trial of repeated dosing intravenous ketamine for PTSD. Hello, everyone. My disclosures are actually located in the link that you received. So I'm told to that you can look at them there. We all know how prevalent and disabling PTSD can be as a condition, and it tends to be chronic in many individuals and who are have been exposed to a severe trauma like an assault or witnessing a horrific accident or other traumas, and they are haunted by repeated memories and nightmares of the event, triggered by reminders. They really avoid triggers. They have a diminished, more limited life, more distant from other people, less interactions. They enjoy things less, and they can be very hypervigilant and have increased startle when exposed to noise. And as you know, the prevalence of PTSD in the general population from studies by the WHO and also studies in the US range from 6 to 8%, but there are some particular traumas, especially those marked by interpersonal violence, where the conditional probability of PTSD is quite a bit higher. So the reason why we embarked on the study of ketamine for PTSD is that it had shown initial promise in depression, and my mentor, Dennis Charney, was interested in examining, we were interested in examining whether it might help for PTSD. And the currently, even back then and even now, currently available treatments for PTSD are limited, have limited efficacy. We know that only 2 medications, at least in the US, are FDA approved for PTSD, and only 4 medications, including an additional SSRI and the SNRI venlafaxine, have shown at least moderate level efficacy. And only about 2/3 of patients with PTSD respond to treatment with SSRIs, and only less than 1/3 achieve complete remission. So a lot of patients who do respond have persistent, significant residual symptoms. And in terms of a trauma-focused psychotherapies, they have the most evidence base. For example, prolonged exposure, cognitive processing therapy, but they are limited by pretty high rates of non-response, partial response, and also pretty high rates, 35, 40% in some studies of treatment dropout, because they can be difficult to tolerate. And also there's a lot of homework and exposure to feared stimuli in between, and also during sessions, of course. And so high levels of dropout. So there's the critical need for novel treatments for PTSD has been described. I'm not going to spend too much on these couple of slides, except to say that, as you know, ketamine is a non-competitive NMDA receptor, glutamate receptor antagonist, and that glutamate, it modulates key modulator stress responses in the brain, and is involved in the formation of trauma memories. And as you probably know, animal studies have shown that repeated chronic stress is associated with synaptic atrophy in key brain regions in the hippocampus and medial PFC. And several years ago, a single intraperitoneal administration of ketamine in rodents was shown to very rapidly reverse the synaptic atrophy in pyramidal neurons. And by 24 hours, one day later, this result of chronic stress was very rapidly reversed by a single infusion of ketamine. And the initial ketamine studies for depression have been done by then, and we're in the midst of running our first proof of concept study of a single infusion of ketamine, which we published in 2014, and individuals who are randomized to either receiving IV ketamine, this should cross over to midazolam, not to ketamine again, or they were randomized 50-50 to midazolam and then to ketamine. And so there we showed initial promising results, and you might be familiar with the study, so I'm not going to spend too much time on that one. And I'm going to go straight to our recently published study last week, which we completed this past year, where we decided to study whether a course of repeated ketamine infusions could basically replicate our initial findings of rapid improvement in PTSD symptoms and also comorbid depressive symptoms, but also if we can maintain the improvement for longer. So this is the overall design of the study. As you can see, we took patients primarily through advertisement, but also referral from other physicians and clinicians, advertisements in the community. We had a couple, because I also work at the World Trade Center mental health program, we had a couple of referrals of World Trade Center responders, rescue and recovery workers who had been exposed to 9/11 and its aftermath. And the cutoff for the CAPS-5, these are actually approximate. There's no published publication that shows these ranges, but they're based on the estimated ranges from Frank Weathers, one of the key authors. And we chose a cutoff of 30, which was approximately similar to a cutoff of 50 from the original, the CAPS for DSM-4, and it's a few points into the moderate range. Most of our participants that on average had severe PTSD, and I'll show you that. So, and they were randomized, if they qualified for the study, they were randomized to receive 6 infusions of ketamine compared to 6 infusions of midazolam. The dose was the usual dose used in most studies, and the typical schedule that most participants, with slight deviations, typical schedule would be Monday, Wednesday, Friday of the first week, consecutive week, second week, Monday, Wednesday, Friday infusions, and then the following Monday was our primary outcome day or week 2, and our primary outcome measure was the CAPS-5, and then they were followed. If they did not respond, they were no longer followed; they were exited. If they were responders, then they were followed weekly for the first month, and then monthly, potentially for up to 6 months or until relapse. Once they relapsed, they were no longer followed. So as I mentioned, the primary outcome measure was the CAPS, the change in PTSD, overall PTSD symptom severity on the CAPS-5, and at 2 weeks, 2 weeks after the first infusion, that Monday after the last infusion. Secondary outcomes were also, we were interested in the change at 24 hours after the first infusion with ketamine, and that's with the impact of event scale revised. And then the MADRS for depression, it's also clinical radar administered, and we administered it both at 24 hours after the first infusion with a revised version of it, and then 2 weeks after the first infusion with a past week, capturing the past week, just like the CAPS-5 is also the past week. And a number of safety outcomes, including during the infusion, any emergence of dissociative symptoms and other symptoms, and then in general side effects throughout, like nausea or headache, etc. So inclusion criteria you can also find in the paper: men and women up to age 70. And basically, we excluded individuals with chronic psychotic disorders and bipolar disorder. We also excluded individuals who had an active drug or alcohol use disorder within the preceding 3 months, or who had recreationally used on more than one occasion, or recently in the prior 2 years, ketamine or PCP. PCP because it acts on the same receptor complex. And then anybody who had unstable medical conditions and who had elevated blood pressure at baseline. They had to have stable blood, even treated hypertension was okay. And then certain medications, a lot of medications were allowed. We allowed, medications had to be stabilized for the prior 3 months, but they could be on multiple meds, like 2 antidepressants, a mood stabilizer, an antipsychotic, for example. We only did not allow long-acting benzodiazepines or opioids. And if they were on short-acting benzos, because of the comparison condition was midazolam as a psychoactive placebo control, they had to be, we would hold the morning dose, the morning infusion. So we randomized 30 participants and 1-to-1 allocation, equal allocation, half of them to ketamine, half of them to midazolam. Everybody completed all 6 infusions with the exception of one participant in the ketamine group who had been had some suicidal thoughts and was quite fragile, about a month and a half, not actively suicidal, but before randomization, and she had not improved for the first after the first 2 infusions, and we thought she was still quite fragile, and we needed to. She had been not actively suicidal, but we felt that it was safest for the patient to be referred for directly for clinical treatment. Everybody else completed all 6 infusions. And that participant, by the way, had not improved on ketamine. We didn't think that she had worsened as a result of ketamine. So you can see here, again, in the paper, you can also see on average, the age in middle adults. Duration of PTSD was on average about 15 years, so quite chronic. The CAPS, past month CAPS score at enrollment was in the severe range. And you can see here, we didn't exclude for comorbid anxiety disorders or comorbid depression. And of course, comorbid depression is quite common in PTSD. And what else do I want to say here? That it was a range of, you can see here the current diagnosis of MDD in a subset to about 2/3, and that the trauma, the most common trauma was sexual assault or molestation. We had some participants who had trauma in childhood, others in adulthood, and others had both. And there was a range of trauma exposures. So these are our primary findings. Basically, there was a significant difference, and clinically, so in order to be classified as a treatment responder, a participant had to, on the full CAPS, the total CAPS score for the past week, had to have at least a 30% improvement compared to baseline at 2 weeks. And that was a standard. There's no clear standard in PTSD randomized controlled trials like there is in depression, but several studies have used this at least 30% improvement. So we decided to use this cutoff, but also even continuously, there's a significantly markedly better response. And that was basically, there was an almost 12-point difference at 2 weeks in the CAPS score, CAPS 5. And then, and the Cohen's D, the effect size, was 1.13. So robust effect size. And what you can see here is the percent by that criterion of 30% improvement, at least that basically 2/3 or 67% in the ketamine group were significantly better, or 30% improved at 2 weeks, compared to only 20% in the midazolam group. 80% were not more than 30% improved at 2 weeks. And we also saw significantly different improvement across all CAPS subscales, except this one was at the trend level, the arousal and reactivity subscale. And we think it could be related to the fact that midazolam is not only a placebo, but it's a it actually can, in the short term, decrease anxiety symptoms. So it's possible that this didn't quite reach significant because they got 6 infusions of midazolam. And it was significantly different in all the symptom clusters. A little bit, if I may go a couple of minutes over, and these are selected quotes from individuals from ketamine responders. And I must say that ketamine responders, some of them had a really amazing or marked response. And in others, the response or the improvement was clear. This is a middle-aged woman who had a history of assault in childhood, and young adulthood. And she said, I don't feel my life, this was obtained after a few infusions, sometimes after all the infusions, in the course of clinical assessments. She said, I don't feel my life is going to end anymore. It made it impossible to plan a future. I want a life now too, after the infusions. And she gave an example where at work she interacted with someone who had been harassing her, bugging her. One huge thing I noticed that is different: before I would have panicked. He's been very aggressive. I don't feel panicky or afraid. So she's able to cope a bit more with her emotions. This patient had been molested growing up. And she, after a few infusions, she says, I feel like a normal person. I seem like a normal person. My brain no longer lets me envision or picture a thought of suicide. This was a patient who was chronically passively suicidal. When she thinks about her past trauma, it doesn't make me feel weighed down. I have to dig out the memory as if from an attic. Before, talking about it used to make me feel a terrible feeling. And this participant grew up in a physical abusive home, but also had been sexually assaulted as a young adult. After a few infusions, she said, I feel like I have energy and want to do things again. I feel safe and able to confront feelings without problems. I could just feel it when I can figure out what happened and why it happened. And she also reported that during infusions, she tried to think about her sexual assault at age 17. And she felt during infusions, she did it herself without any, because we didn't have any instructions for people to think about anything in particular. Like I made peace. I could go past it. I can let it go. It's been a gradual acceptance. I haven't felt this safe in a long time, meaning after the infusions. This is the concomitant improvement in comorbid depressive symptoms. And you can see the improvement over time by 2 weeks. And here I wanted to show that even though we did not find, it's a smaller sample size. The first study looking at 24-hour changes by 24 hours had 41 participants. Here we only had 30. We didn't see a significant difference. Actually, it was not significant at all on the impact of MN scale at 24 hours. However, when actually Sarah Kosti, one of our co-investigators, was present here, she actually compared these were the responders at 2 weeks, and these were the ketamine non-responders. And this is the ISR, PTSD symptoms, this is the MADRS, depressive symptoms. You can see that in those who were going to be responders at 2 weeks, you already see a difference in how they're responding. They're already responding at 24 hours on average. So this is the time to loss of response. So the median time to relapse, or I should call it loss of response, was about a month after the full course of infusion. So about 6 weeks after the first infusion, we started seeing people losing response between about 2.5 weeks after that primary outcome, so about a month and a half after the first infusion. And some of them remained better for quite a bit longer. And then 2 of them didn't come back for additional assessments, were still improved a couple of months later. And this is just to show you, you can see this in the paper also, that there weren't significant acute dissociative symptoms, or certainly psychotic, or we checked for elated mood. In terms of acute dissociation, there was especially the first infusion in general, where is that actually here, the CADS, was a bit more pronounced, but not really. There was a difference in ketamine and midazolam. And it resolved, it really, the first assessment, the assessment captured here is at 40 minutes right at the end of the infusion. And the next one is not until 120. But typically people who had some dissociative symptoms, like feeling floating, or like objects in the room, or their vision was a little different. It actually resolved maybe 5-10 minutes after the end of infusion, and by 120, it was resolved. So in conclusion, we showed with this first randomized controlled trial for PTSD of repeated IV infusions of ketamine that they were associated, this course of infusions was associated with a large magnitude clinically significant improvement in PTSD symptoms compared to midazolam. And we saw this improvement across all symptom clusters, except not quite in the alterations in the arousal symptom cluster. And the improvement was maintained for a median of about a month after the full course of infusions, and that it was well tolerated with no serious adverse events, side effects. And in those who were going to respond to ketamine, we saw rapid improvement in PTSD symptoms 24 hours when assessed 24 hours after the first infusion, even though we didn't see a difference in the 2 groups as a whole. In terms of future direction, we're have a pilot neuroimaging study. And then we're very interested now in finding out how to maintain that response after an initial course of infusions. And of course, with esketamine and depression, that has been achieved by continuing to administer esketamine over time. esketamine studies would be good to conduct in PTSD with intranasal administration. The other possibility, there's also a lot of interest in the field, is the addition of a trauma-focused therapy, especially a brief trauma-focused therapy, because ketamine is thought to open a window of increased neuroplasticity in the brain. And also some animal studies have shown that it seems to enhance fear extinction learning in animals. And so adding a brief trauma-focused psychotherapy during that period, which is thought to work by fear extinction as one of the mechanisms, might be a good way to maybe, the ketamine might enhance the workings of the trauma-focused therapy, which in turn might maintain the response for longer. I'm sure we will get this into the discussion, but we have to be careful in terms of the timing of the therapy intervention with respect to the ketamine infusion, because experimentally, there's a paper by Corlett et al. Experimentally, when individuals underwent fear conditioning the day before, and then the fear memories were in healthy individuals were represented during the infusion, they can actually become stronger. So I just wanted to thank everyone, including Dennis Charney, who started this line of research on ketamine for depression and initially PTSD and was collaborator throughout the study. And also special thanks to Sarah Costi, who was instrumental in the study, James Murrow, the head of the Depression Anxiety Center where the study was conducted, and basically a whole lot of people co-investigators and research coordinators and the patients who were really instrumental in this study. Thank you.
Great. Well, that's terrific. Thank you very much indeed, Adriana. Congratulations on that study. I'm going to pick some questions here out of the Q&A.
Can I start the sharing, or maybe if I have to go back to a slide, then I leave it, or what do you prefer?
I just leave it as it is. I think it'll be fine. I think people can see you and the slides. So
perfect.
Just in relation to sort of data in the paper, were you able to explore any links between the acute response and the CADS? So you showed the CADS, but was it actually related to the response?
We have not yet conducted those analyses. In our previous study, we had not with the single infusion in PTSD. That's an excellent question, except we also didn't look at the subscales. And more recently, one of the subscales of the CADS seems to be potentially related to better response. So we're about to conduct those analyses, actually. Very good question. So to come soon.
Can you comment on the patient who dropped out due to worsening symptoms?
Yes, so she had very severe PTSD and depression, and she intermittently had acute dissociation, acute dissociative symptoms, and so she had been still very fragile, had not had any suicide attempts recently, but still passive suicidal ideation, intermittent, and then closer to the study, she was able to contract no harm, denied any active suicidal ideation, and hadn't had, very recently before the study, had not had any dissociative reactions, but she did a month prior, if I remember correctly. So we decided to enroll her. We knew that individuals who get better in general seem to get better pretty fast. And so she had already 2 infusions without much improvement at all. And by the time she came on that Friday for the 3rd infusion, she reported that she still was experiencing some passive suicidal ideation. And also she had one of her dissociative episodes where she did not remember, but apparently she grabbed a set of keys and just scratched her skin and then threw the keys and came to and didn't know exactly what had happened. And so at that point, when you get to know a patient also a little bit more, she had been assessed very thoroughly, but we felt that given that she had not responded to these 2 infusions, she was still experiencing passive SI, and she had had this dissociative episode, which was consistent with prior episodes she had had before ketamine, We did not think that this was worsened because of ketamine, but we thought that it would be, rather than her being in an experimental research study, that she should really be referred for treatment. And this particular patient was not taking any medication at the time. So we felt that she should be restarted. She had tried SSRI in the past, but she did not, she had some nausea, vomiting, didn't tolerate them. So she was not on current medications. And so we actually exited from the study just to be certain that we kept her safety first, and then referred her for clinical treatment immediately. I don't know if that answers the question.
I think it's a very full answer. Thank you. I think the answer to this is no, but was the dose of ketamine increased for participants who were non-responders at the first or second sessions?
It was not. This was a fixed dose, like most other studies have been, but there's interest in figuring out if individuals who don't respond, and whether that's related to extent of dissociation or not, that still remains a point that has to be researched more. And so it's possible that those individuals who did not respond might have needed a higher dose. Everybody received 0.5 milligrams per kilogram. It was by weight, and it's possible that some individuals are faster metabolizers.
Sure, and of course, people who are heavier get a bigger dose, don't they?
They get a bigger dose, but then regardless also of the BMI, it's possible that some people metabolize ketamine much faster, or its metabolite or other metabolites. And so some individuals, it's a good point in the future. For research in the future as well? Do non-responders, should we try and give them a higher dose? It's not known. Most studies have been done with fixed dose.
Thanks. There's a question here about methodology. Was psychotherapy permitted during the double-blind treatment? And
It was.
If yes, was there a difference in those receiving psychotherapy? And then a related question, or an additional question is, can you say anything about the success of the blind?
Yes, so in terms of psychotherapy, we did allow concomitant psychotherapy. The majority, there were about more than half in each group, actually have this information in the paper in the supplement, were receiving psychotherapy. It was generally not an evidence-based for most individuals form of psychotherapy. It was generally supportive therapy. One person had been received, and it had to be stable we didn't have anybody who started therapy at the same time as this, which would, then it's hard to know what's helping. So as long as individuals had been in therapy for quite some time, we did allow that. And we didn't do any analyses of whether individuals would do better. It wasn't, some people receiving, we're going to therapy less than once a week. Some people, so we didn't do any analyses by whether people in therapy did better or not. I mean, the improvement was pretty, when you see an improvement, sometimes see it after a few hours when you're still there about to discharge the patient, and it's sort of immediate, the improvement with ketamine alone. The question is, would the therapy maintain that improvement for longer? I do have one example of a participant who had very extreme dissociative reactions in therapy, and where she was reliving her assault, and it was very, very difficult to control. And I talked to the therapist afterwards with the patient's permission, and she said it was almost like a miracle. This patient was able to talk about the trauma during the therapy and stopped having these dissociative symptoms altogether, the episodes during therapy sessions when they would touch on the trauma. But then eventually she did relapse after a few weeks. And actually this patient was referred for further infusions. We have not studied, I think that we have to do a separate study of the combination of therapy and ketamine to examine that question. And in particular, being very mindful of the timing and I mean, I have something else to say about that, if I may.
Perhaps we could defer that just into the
to the discussion. Yes, for people who want to stay. There's a lot to say there.
A lot more to say, so that would be great. But I'd just like to ask. There's one question here that I think is sort of pertinent for this. Now let's just see. No, excuse me, I was trying to find it again. No. Did you observe anxiety as an adverse event after the first doses of ketamine? So did you see any anxiety as an adverse event? Or
no. During the infusion is when we didn't see any worsening of anxiety. Either no change, and some people did not improve much, or significant improvement in anxiety. So for example, one participant who was a star improver, I think her CAPS was like 40 something and went down to a 4. She was had been scared of crowds, and she started going to, her partner was very interested in like baseball, and she had no problem going to a stadium for a game. So we did not, that's like one of our best responders. During the infusion, some people felt some anxiety, and for others it was a pleasant experience. So it really varied, but we did not see worsening of anxiety.
Okay,